Okay, hi everybody, welcome. We're so thrilled to have you guys all here. We're just going to introduce ourselves quickly and then we'll get going. I'm Max Greenky, and all four of us are hip and knee replacement surgeons. It's all we do, it's what we love to do. We all did an extra year of training to do it.
I'm Kevin Kopko. I'm Anthony Orio.
David Quinzi. Okay, good. So we'll go ahead and get started. And we thought we'd start basic, just by sort of first, reviewing what the normal joint is, what arthritis is, some of the non-operative treatments for it, some of the surgical treatments, and then just get you up to speed on some of the newer things going on in the field. So, joint replacement, we're talking about specifically hip and knee replacements today, so that's what we'll focus on. And so, the hip and the knee joints, two different kinds of joints. The knee is more of a hinge joint, and the hip is more of a ball and socket. But in a normal joint, um, the surfaces that rub on each other are cartilaginous. So cartilage is sort of that's the shiny stuff on the end of a chicken bone when you eat it. And in its normal state, it acts to cushion the joint when we walk. It allows the joint to move freely without friction and without pain. So the hip joint, again, it's made up of a ball and a socket. The top part, or the ball, is made of the top out of our thigh bone called the femur. That makes up the femoral head, and the socket is made up of our pelvis. And the cartilage surfaces here on the head of the femur and then in the socket itself. Knee joint, like I said, is more of a hinge joint. It really has three compartments. The inside one called the medial compartment, outside one called the lateral, and then the last one people tend to forget about is behind the kneecap, the patellofemoral compartment, where the kneecap sits and rides in the groove on the thigh bone. Okay, so what is our arthritis? So arthritis is basically wearing out of the cartilage and then the other soft tissue in the joint. And so in the knee's case, it can also be wearing out of the meniscus. And it can either be from osteoarthritis, which is sort of the regular wear and tear. That's what the vast majority of people have. It can be from rheumatoid arthritis or other inflammatory arthritis, so meaning systemic inflammation that causes the tissues to deteriorate. And then it can be post-traumatic, which means you had an injury when you were younger, and that caused you to wear things out. But it's basically wearing out the treads of a tire. And so on here, you can sort of see a schematic of what a normal joint looks like. And then as you wear it out, the joint starts to react to the process in the sense that it changes the quality of the bone. You start to get bone spurs, and then you do wear out some of the soft tissue stabilizers. So here's just an X-ray version. So you can hear on the left where my cursor is, this is a normal knee. So bottom part of the thigh bone called the femur. Here's the top part of the big leg bone called the tibia. And if you look where my cursor is here, there's a nice gray area between the two bones. Now, if you come over here to the middle one, you can see on the outside still some good space here. But as we move to the inside, you can see that space has gone away. And so when you hear bone on bone, that's what we're talking about. And so if you come over here, you can see here the cartilage is worn away, but you haven't seen a lot of the other changes. But if you look around here, you see sort of these jagged pieces here, here, over here where my cursor is, and then just how the color of the bone changes. That's the reactive changes that goes on with arthritis. So hip here, this is a normal looking X-ray. Again, top part of the thigh bone called the femur makes up the ball and the socket. And then the socket is made up of the pelvis. So to progress here again, normal hip. So if you can see here, this is the space between the ball and the socket. Again, nice gray area around the whole hip. If we come over here, you can see still some gray area, but as we come in, starting to narrow right here. And if you come over here all the way on the right, you can see that space is almost completely gone. Instead of being a perfectly round ball, it's starting to flatten on the top. And then you can see here, they almost look like little circles. That's, again, changing the quality of the bone. Okay, so the bottom line is that once that starts to happen, nothing we can do to reverse the process. And so we're treating your symptoms. And so Kevin's going to start talking to you, treating some of the treatment, and then we'll get to the surgical treatment later on.
So essentially, all of my talk is on this slide, but we're going to go through a bunch of other slides here as well. AHKS is the American Associations of Hip and Knee Surgeons. They've developed what are called clinical practice guidelines for treatment of knee arthritis. And so this slide really is a summary of all of the treatment recommendations. There are a lot more not recommended treatments for knee arthritis than there are recommended treatments. What we know is really important is physical therapy for patients, wellness, education, kind of go hand in hand. Understanding the disease process really matters so you know how to treat it. Medication recommendations, Tylenol or anti-inflammatories. Anti-inflammatories do have some side effects. You can't use them in patients with unstable blood pressure, patients on anticoagulation, GI issues. So there is a topical anti-inflammatory that's available over the counter now called Voltaren or diclofenac cream that went over the counter about 3 or 4 years ago. Weight loss is a big thing in management of arthritis and maintenance of joint replacements. The force that goes into the joint, at least in knee replacement, it's a 4 to 5 times multiplier. Cortisone injections are recommended, as is a walking aid to decrease the joint reactive forces. It's important to note that you should be using a walking aid, if it's a cane, in the opposite hand, and it should be on the ground when the affected joint's on the ground. That'll get you the correct gait and decrease your joint reactive forces on the affected side. What are not recommended is narcotics. Don't think that's going to be news to anybody. Biologic therapies. There's a position statement from both the AHKS, ACUS, and AAOS, the American Association of Orthopedic Surgeons. They have strong position statements against biologic therapies in advanced osteoarthritis. So biologic therapies would be platelet-rich plasma, stem cell, those kind of therapies. We know that acupuncture, red light therapy are not recommended treatments for arthritis. Supplements don't really work as well. Glucosamine and chondroitin, turmeric, it's not really well absorbed by the GI tract. So it's really hard to quantify the effect of those things when they're compared to a control. Other injections, gel shots are not recommended in the treatment of arthritis anymore. And that's kind of the one that's on here that's a little gray, because we still do them by request. They seem to work about a third to half the time. But in large studies of blinded patients who don't know what they're getting, cortisone will be superior in all those studies. In the setting of arthritis, it's no longer recommended to do meniscus surgery or quote unquote arthroscopic cleanouts. Those are surgeries that used to be done in the past, debriding cartilage, removing them, but that's kind of like taking tread off your tire to make it more level and then wondering why it's wearing out faster. And then shoe wedges, insoles, or bracing. There was a desire to do offloading bracing in the past, and that's kind of the same idea as shoe wedges. That's been shown to be less beneficial, and most of us at least avoid it in the average patient unless there's true instability in the knee. So education, you have to know what your disease is and how you're going to treat it and how you're going to manage it. It's better to be painful and mobile than painless and stiff. It's better to move through your arthritis pain and keep moving, keep your strength up, keep your range of motion up. The hardest thing to recover in joint replacement or in arthritis is range of motion. The surgery is more for pain control, to improve your quality of life. It's not going to just restore motion automatically because, as Max talked about, we work on the joint surface. The muscles, the tendons, and ligaments are all affected by this, but they're not something that we're replacing. As far as weight loss goes, every pound of force you lose, every pound you lose can take up to 5 pounds of force off the knee, particularly when you're going up and down stairs getting out of a chair. So it's a massive force multiplier when you start thinking about 5 to 10 pounds of weight loss times 10,000 steps a day. You're talking about 250,000 to 500,000 pounds of force off the knee. And then we kind of talked about on the last slide, assistive devices. You want to keep that in the opposite hand and it's on the ground when the affected foot's on the ground. One of my favorite slides. We get asked in the office all the time, heat or ice, and if anybody remembers this movie, Rookie of the Year, funny one from when I was a kid at least, it's really whatever works for you. A lot of this is common sense. There's not a right or wrong answer. Heat can work, ice can work. Some patients like one, some patients like the other. You're not going to make yourself worse. Just be aware with heat, particularly post-operatively, you have a little more swelling potential. Anti-inflammatory. So non-steroidal anti-inflammatory drugs, they're available over the counter and prescription. They should be used in the appropriate patient and the appropriate modality. If you're unable to take an anti-inflammatory drug because of your blood pressure, your kidney function, your stomach, or you react to them, there's a topical diclofenac cream that's now available over the counter. Other topical options, I tend to recommend Voltaren specifically. You know, a lot of people like Blue Emu or Aspercreme. These all have different modalities. The one that I would specifically just mention briefly, you know, Lidoderm or lidocaine patches, they affect the skin only. They don't really help the deep disease. And Voltaren or the drugs that cross the screen or across the skin should have more of a therapeutic benefit. Arnica is a homeopathic drug that has anti-inflammatory properties. The biggest problem that's we've seen with that in the past is when you're using a controlled substance or a strength controlled trial of it compared to diclofenac generically, you'll get the same effect. The problem is homeopathic medications aren't controlled for strength, so you may get a strong batch once and then get a weaker batch the next time because they're not regulated. Intra-articular injections. So it's relatively easy to do a cortisone shot in the office. It requires no approval. It's relatively cheap. And it offers kind of the quickest relief we can offer to any of our patients that's non-surgical. They take about 5 to 7 days to work. They can last up to 3 months. You cannot have surgery within 3 months of an injection in the same joint. So you can have one in the opposite knee and have surgery. You can't have it in the same knee and have surgery on that knee for 3 months. Cortisone is an anti-inflammatory drug. By dosing it locally in the knee, you make the joint fluid a little bit less inflamed. It becomes thicker and oilier, acting more like a lubricant. And that offers some symptom relief. It does not reverse the disease process. Hyaluronic acid or gel shots are the other drug that's available. Again, we still do these by request, but they are no longer recommended. They are more expensive and they tend to be a little more uncomfortable when you receive an injection. Biologic therapy. So these are the specific statements I kind of mentioned a little bit earlier. Essentially, in the setting of arthritis, particularly moderate to severe arthritis, all of the experimental treatments that you can hear about, PRP, stem cell, any kind of biologic or regenerative medicine technique is not recommended by the societies that govern orthopedics. And I think that's important because all of these are considered experimental. We've seen lots of patients have them. They're very expensive. We don't recommend them. They're not recommended by us or our societies. And I think that it's a scary practice that's experimental, that's being sold as a knee replacement alternative, and there's no real science or data that it works. And so I think we're going to move on to joint replacements and when to do it. And I think Dr. Quinzi is going to talk about that.
Perfect. Thanks, Kevin. So when do you consider a joint replacement? So I typically tell folks they will know when the time is right, but typically it's a quality of life thing. And when, day-to-day quality of life is being affected and you've tried some of the conservative stuff, I think it's time to consider at least talking to a surgeon about a joint replacement. So, we just updated these slides. The old data we had was from 2014. But just in 2024, 1.9 million total knee replacements were performed. That almost has tripled since 2014. And 1.2 million total hip replacements were done in 2024. That almost doubled from 2014. So overall, with regards to joint replacement, it's a very safe and successful procedure. We do have a high patient satisfaction. Again, it improves quality of life. It can improve mobility, and then overall actually improves life expectancy. And we've made a lot of changes since the early 2000s with regards to the implants. And, I'll talk more about the implants and then technology we can use in the operating room. So what is a joint replacement? I mean, that's a common question that's typically asked. I like to say it's a resurfacing or a cartilage replacement procedure. What are the ingredients? So there's the super alloys or metal, which is typically white on the x-ray. You can see an x-ray of a knee replacement above. And then these are typically made of, for the knees,
cobalt chrome, and then titanium. And then there's polyethylene, which is plastic, and that's the invisible portion on the X-ray in between the two metal components. And then for a hip replacement, it's a combination of metal, plastic for the liner, and then ceramic usually for the head or the ball and socket component. So total knee replacement surgery, there's really two ways to do them in the main sense. There's a traditional or the manual knee replacement. That's performed using intraoperative cut guides. There's an intermedullary or device that goes into the femur or thigh bone used to create the cuts, and then an external guide for the tibia or the shin bone. And then there's some robotic platforms that we utilize. Mako is one of the ones we use in our practice, and that's a robotic knee replacement. I'll get more into that. So robotic assistance in total knee arthroplasty. I mean, the screens you see up there are typically on the computer when we're performing that surgery. Robotics in total knee provides for patient-specific alignment. We do get a CT scan preoperatively that helps us plan for the procedure. I say customization, it's not really a custom implant, but allows us to fine-tune things to a half a degree, again, to try to match and recreate the pre-arthritic anatomy. There's some intraoperative haptics as well. If you think about lane assist in your car, there's actually boundaries that when the saw blade starts to approach that, it will give you a warning or, shut the saw blade off sometimes. So it can be a little bit safer. With regards to a partial knee replacement, that's for patients with arthritis really only affecting one compartment. The most common one is a medial partial knee replacement. Typically for those, it's a little bit shorter rehab as compared to a full total knee replacement. Typically patients have a little less pain, but I would say these are much less commonly done because most patients, again, have arthritis in multiple compartments and not just one. These are typically done for younger patients as well. So robotics in partial knee replacement, again, it's a patient-specific alignment. The big things with these partials, you want to prevent overstuffing or overcorrection of anatomy, because that can lead to, arthritis development in the other compartments. And again, overall, it's a quicker recovery as compared to a full total knee replacement. So benefits of a total knee replacement, our hope, again, after recovery is to eliminate or at least reduce joint pain. Definitely, we try to increase mobility. I will say, though, the best predictor of that is how much range of motion you're bringing to us preoperatively. Again, our goal is always to improve quality of life, and we can overall correct some deformity. There's two forms of fixation that we talk about, cemented versus cementless. They're both good options. Typically in folks with good bone quality who are a little younger, we go with the cementless fixation, and your bone grows into this implant and it becomes a part of you. Cemented fixation, again, we grout or glue the implants into place. Again, both are gold standard at this point. So total hip replacement, again, we talked about this a little bit earlier, but it's a replacement of the socket or the cup. And then on the femur or thigh bone side, we're using a metal implant that we're pressing into the bone. That implant grows into the bone with time. It takes about 6 weeks to fully integrate, but it's immediately stable. A plastic liner, and then a ceramic head. Again, there's several surgical approaches to the hip, and I'm going to touch on that a little bit right here. Perfect. So the main approaches we perform are the anterior or the posterior approach. I think most of us at this point are almost, what would you say? I'm about 100% anterior. You guys are probably in the high 90s, I would say, if not 100%. For the anterior approach, the patient is placed supine or on their back. Some benefits of that, you can either drape out one or both legs, and that can help with leg length recreation. Regardless, X-ray is very easy intraoperatively for component positioning, again, and trying to get the leg lengths as close as possible. Benefits of that approach, it's a lower dislocation risk as seen in literature. And we tend to say it's muscle sparing. We try not to cut muscle with this approach, so potentially less pain post-operatively and a quicker recovery. The posterior approach, which, the incision is not in the buttock, it's really just lateral and can be minimally invasive. The patient is actually placed on the side for the surgery, and the implants are placed or oriented via anatomical references. And then robotics and total hip arthroplasty. Again, you get a preoperative CT scan. I think in our hands, it's more helpful for complex cases. post-traumatic osteoarthritis, patients with pre-existing hardware, congenital deformities, or spinal pathology. I would say overall, this is not less invasive. You do need to place pins in the pelvis to facilitate that surgery, but it can be used with any approach, either posterior, anterior, or lateral. And then again, the benefits of a total hip replacement: eliminate or reduce joint pain, increase mobility, and then again, increase life expectancy. How long will it last? I mean, that's a common question we get. This is an older study. It does include patients that had surgery done before 2005, after which they updated the plastic. But, they looked at 60,000 total hips, 55,000 total knees. The 20-year revision risk was 15% for a total hip, 10% for a total knee. But again, I think with the new technology, with the new plastics, I mean, we're seeing hips and knees last 20, 30, 40 years even. And I'll hand this over to Anthony to finish things off for us.
So we talked about what's arthritis. We talked about what to do before surgery. We talked about some of the options surgically, both hip and knee replacements. And now we're going to talk sort of where we do those operations and sort of some of the post-operative things associated with having either your hip or your knee replaced. So these are considered outpatient operations, and we obviously have always done them at hospitals. We continue to do them at the hospital, but we also do both of these operations at our surgical center in North Syracuse. And this is just basically another statement from ACUS talking about sort of the success rate in their position about performing these operations, both hip and knee replacements, in an outpatient setting. I think probably one of the few good things that came out of COVID was probably doing these operations on the same day basis. The hospitals were shut down for a long period of time, and over the course of a few years when we were all sort of bundled up due to COVID, we really were able to optimize and come up with protocols to put in place both for our patients to have these operations done successfully and, more importantly, safely, on an outpatient basis. So this is our surgical center. It's a picture of it over in North Syracuse. I talk pretty routinely with my patients that I refer to this place as the Mecca of orthopedic care in Central New York. There's very few places that, number one, does the amount of operations, hip and knee replacements, that this facility does, and it's truly a very, very unique place, not just for the state of New York, but around the country. And we were, in regards to the amount of these operations performed, the number one place in not just Onondaga County, not just the state of New York, not just the Northeast, but in the country. So we're obviously doing a lot of these for our patients, and we've got a really, really nice thing going over in North Syracuse for these operations. So what to expect after? Obviously, we've talked a little bit about sort of what the operation entails. So obviously, if you do decide that getting it done at the surgery center, is the most beneficial and acceptable for you, the vast majority of our patients are planning and are going home, the same day. There are safety nets in place at the facility that if patients, aren't ready to go home for, unforeseen reasons, there are beds overnight for a small proportion of patients that you can see that have to spend the night and go home the next day. Obviously, after your operation's over, you're going to see a physical therapist there. They're going to walk you around, do some stairs, and then go home. In regards to doing these operations at the hospital, obviously we're still doing them. Obviously, we take care of patients with varying amounts of comorbidities, some healthier than others. And obviously, settings like a outpatient, may not be the safest for them. So we do these operations, still at the hospital. And the vast majority of patients, the goal, when we take you to the hospital, is to spend the night and, go home the next day. this is just sort of talking about sort of what we're trying to accomplish, after the operation. I think we do a really, really, really good job before this operation of inundating our patients with tons of information, sort of about the whole process, both the day of surgery and sort of looking forward the first few weeks after, to provide everyone sort of with realistic goals and expectations, of what surgery is going to entail. As I alluded to, obviously within a few hours after surgery, you're up. Most patients in a surgery center are spending anywhere from about maybe 5 hours or so recovering and then going home later that day. Obviously, this is major surgery. These are major orthopedic operations. And anytime you do an operation, there's obviously, risks involved. You can see, obviously, there's a varying amount of risks. But at the end of the day, all of these risks are very low. We usually quote somewhere on the magnitude of a half to a full percent, which is still a very low number. But when you're doing surgery, when you're doing operations, unfortunately, the number 100% just doesn't exist. There's always going to be a small theoretical risk of a complication. Sort of just goes back to sort of the crux of a lot of the things we've already talked about. Why would you do this? Why would you proceed with a hip or knee replacement? And the goals, obviously, after surgery are to see a physical therapist because there's going to be a period of recovery. And everyone sort of follows their own road in regards to getting to the finish line. Some people, it's a much more arduous process, and some people, it just sort of, comes easily. And that sort of gets back to, before the operation, sort of being, in as best as shape and as being as optimized as possible to allow you to have a successful outcome after these operations. In regards to knee replacement, the one thing that, we're very cognizant of and we're very aggressive in keeping an eye on is obviously your motion. We obviously don't want our patients to get stiff after knee replacement surgery, and obviously physical therapy is a very integral part of minimizing that risk of getting stiff after that operation. This is just some data from our physical therapy offices in regards to comparing sort of our patient cohorts of patients that we operate on that go to our physical therapist versus sort of the national average in regards to satisfaction and visits. I think the one big thing is if you look at those numbers, it's almost about just under a 50% difference in visits that patients are still getting the same results, better outcomes. They're extremely satisfied, and we've looked actually at our manipulation rates, which basically is looking at sort of how stiff some patients get and if they ultimately need to go back to the operating room. And our therapists do a fantastic job of keeping that rate lower in comparison to patients of ours that end up going to other physical therapy offices. Recovery period, so anytime before an operation like a hip or a knee, I usually tell people, it's a 12-week process. It's definitely going to be a few months. Sort of as I alluded to earlier, everyone sort of follows their own unique pathway. And that's just what makes us unique as individuals. But you want to have time. These are operations that are not meant to be squished into your schedule, into your life. There should and should always be a period of time where you have enough adequate time to sort of do your therapy, worry about your recovery, and have a successful outcome. Just because of sort of that time period it takes to get back and be mobile. Common questions: when can I go back to work? When can I drive? When can I get back to the things that I once did, but now I want to get back to do since I have my new knee or my new hip? And a lot of these things are very specific to the individual. It's specific on how fast they're recovering. It's specific sort of what you do for a living. Obviously, if you're a construction worker on a telephone pole, that's a little bit different than an individual who works remotely from home. These are specific things that will be discussed with your doctor, sort of as you progress through your recovery process. In regards to driving, I say the soonest you'll ever be able to drive a vehicle, doesn't matter right or left, is 2 to 4 weeks. So the average is about 3 weeks. Work, just like I alluded to earlier, sort of all over the map. You'll have some patients within a few weeks go back and remotely maybe start working. And then, like I said, hopefully about 3 weeks, maybe drive a car and get back into the office. And then our heavy laborers, our construction workers, that's going to take a few months, to get the strength back needed to do what you do for a living. Driving, sort of the same thing. Obviously, this is a thing that's probably universally asked at that first visit. After your hip or knee is replaced, in regards to, when can I get back behind the car and drive? Obviously, it's about safety. And usually the earliest sometimes is about that 2 to 3 week mark. Sporting activities, same sort of thing. I let most of my patients, my magic number is around 6 weeks. That's not to say that there's probably individuals that do stuff before 6 weeks. But usually around that 6 week mark, as David alluded to earlier, most of the implants have now started to, especially in a hip replacement, have started to grow into your own bones. So the issue sometimes is doing a little bit too much too fast. So I think, golfing, chipping and putting, I think at 6 weeks a very reasonable thing to do. But it's the same thing. Nobody's going back to play college football after getting their hip or knee replaced. It's around that 6 week mark that I feel most of us are pretty confident in letting you start to do the things you want to do. And this is just a slide, just stating about our joint registry. So we collect data on all of our patients after we replace their hips and knees, and we have a very, very, very robust joint registry here at SOS. So we do take this very seriously in regards to how our patients do, and are, very frequently looking at ways to continue to do things well, like we've always done, but to improve things if there are things that need to be improved. Very common question, I think, in the office is sort of where to find information about hip or knee replacements, arthritis of the hip or knee, and these are just a few websites and sources that I think all four of us would recommend in regards to finding information that's valid, truthful, and good for patients. So I'd like to obviously thank 670 people for signing on and listening to us talk a little bit about hip and knee arthritis, surgery, and sort of what that entails. We've had some questions submitted early before, and I think we're just going to rattle off some of the ones that we got, and we'll go from there.
Yeah. We can start. It's been a while since I talked. We'll go off the top here. So first one, is there an age limit for knee replacement? We can add hip to that too. And so I think for me, it's not necessarily an age limit. It's looking at the patient and looking at globally and your other health issues, social issues. So, there's patients that who are in their 80s or even early 90s who are independent, they're healthy. And if your hip or knee is the single issue that's really holding you back, I've done a replacement on them. And then there's patients in their 50s and 60s who have a lot of social issues, a lot of medical problems, who I say, it's really not safe to do it right now. So I think for me, there's not an age limit. It's more of looking at patients individually.
I think probably somewhere between 30s to 90.
Yeah,
early 90s.
My oldest was mid-90s.
Yeah.
But I think, like Max alluded to, it's not so much the age, it's the
functional status.
Yeah, it's looking at you.
It's a lot better to be 90 going on 60 than 60 going on 90.
Yeah. Okay. Anybody want to take?
Is there a set BMI you ask your patient to lose weight to? So this is something that I think the four of us would be very honest and truthful in the sense it's something we continue to discuss and come up with sort of what the number should be in regards to BMI. What BMI refers to is body mass index. It's a number that's generated by your height and weight. And what has been shown is sometimes with significant elevations of BMI associated with some other comorbid conditions, like diabetes and stuff like that, it can predispose you to having a bad outcome or an adverse outcome once you get your hip or knee replaced. So these are probably conversations that the four of us have on a very frequent, albeit probably daily basis in regards to what our number or cutoff is. And currently our number is, we use a number of 45 as a sort of a cutoff of patients below the number of 45. We feel confident, as long as patients are medically optimized, that we can do a good job of replacing their hip and knee. The question is, if your BMI is above 45, what does that mean? And usually for my patients, it's an honest and frank discussion in the sense of I personally just like to see some sort of weight loss. Have I replaced a hip or knee with a BMI above 45? Yes. But I would say that person with the BMI above 45 has lost weight for me. Their weight and their BMI is not trending upward, but it's trending downward. And they also probably are fairly well controlled with their other comorbidities.
Yeah, I think that's the key. It's not necessarily, it's like the age thing. It's not looking at a number or a cutoff. It's saying, what does your global health picture look like? Do you understand the risk? And can I do a good job?
I think that's the risk is the biggest thing. And the risks are dramatically different. And the risks start to go up at a BMI of 35, you start to have higher risks. And at 40, every point you go up, it's an incremental increase. So understanding that you're high risk and your family understanding that is important.
But at the same time, we know sometimes it's really hard to lose weight when you've got a terribly arthritic joint. So,
and we have resources too. I mean, we have BMI reduction protocols. We have referrals to dietitians, and we can get you with the PT to try to do some, learn some exercise you can do with arthritic joints.
So, what is the longest number of years that someone still has their original hip in use? So I have revised a hip that was put in before I was born. So I think it's late 30s to 40 years. I'm sure that the ones that we're putting in now, like when you look at our registry data, when we look at what we know they last, some of all that data is skewed because it's including data of older implants. And so since the modern plastic came out around 2005, it became standard. We're not really seeing significant wear in the average well-positioned, well-performed hip replacement. They wear at about 0.1 millimeters per year. The plastic's on average 4 to 6 millimeters thick in the thinnest versions. So I think all of us comfortably think these are going to last 20 to 30 years in the average patient in the hip, and probably similarly in the knee, because the knee revision risk is a little bit higher.
Can you replace a hip and the knee at the same time on the same leg? I would say yes, but I don't think I would recommend that. I think that's a lot of
Single femur replacement is not recommended.
Yes. I would think that would be a lot to recover from. I usually say get the joint the one joint we replace feeling well, get that being the strong limb, and then, kind of go from there.
Another common question to pick out I get a lot of questions. Can you do the two hips or two knees at the same time? And historically we used to do that a lot. We've sort of gone away from it just because physiologically it's a big hit to you and it's hard to recover if you don't have a good leg to stand on. And then the second thing is all those medical risks that we talked to you about, more than double if you do them at the same time. So there's extenuating circumstances when we do, but try to go away.
And Blue Cross no longer lets you do it. That's going to be the other thing that's people are going to face now. They put out a position statement. I mean, the risks are dramatically higher for number one that we don't talk about normally, death, for bilateral joint replacements.
I feel like we talked about the rest of them. Is there more that they want to answer?
Yeah. So, one of the questions that came through was something I kind of hit on a little bit. Glucosamine chondroitin pills move free, are they recommended? So there's actually a strong recommendation against glucosamine and chondroitin. So in a randomized controlled trial, glucosamine was found to be 30% effective and the placebo was found to be 50% effective. So it is a strong recommendation against glucosamine chondroitin, and really any supplement from a joint replacement surgeon perspective. None of us are recommending any kind of supplement because there's no data that in really high quality research studies that they work well. And when we talk about ACUS and AAOS and those clinical practice guidelines, those treatment recommendations, joint replacement's been at the front, the cutting edge of making better outcomes, better implants, better surgeries, and happier patients. There's a ton of research and resources invested in it. So when we say we recommend something, it's recommended because there's data. The same reason why when we don't talk about something, it's really not recommended or recommended against in that regard.
Let's see here. Does there have to be 90 days between a cortisone and or a Synvis shots? I think Kevin talked about that. So there's a little bit of an increased risk of infection if you do within 90 days, and whether it's from the steroid and the cortisone or just violating the joint from the outside world with a big needle. The data is pretty clear on it. Now, is it a huge increased risk? No, but it's a terrible complication when it happens. So we do make people wait for it.
That question.
Can a hip injection stop arthritis or slow arthritis? So, none of the injections, like I said, all of those treatments that Kevin went through, that doesn't reverse the process or of arthritis or halt it in steps. It's designed to make you feel better. So I think we're all in favor of the research for that and the field going in the direction. We just don't have it right now.
What else? Weed or THC for pain control. I tell patients, that's not something that we prescribe, but if they, there's alternative ways of managing pain, and if that's something they're comfortable with, I typically say start slow and go from there. But I don't think I typically recommend it, but I don't recommend against it either.
None of us are licensed to prescribe that.
Yeah, none of us are licensed to prescribe, but I basically say the same thing that David says.
There's research on it. I don't think we know enough, and I don't think it's simple to control. Is an MRI needed to determine if surgery is necessary? So in our world, we really don't need MRIs. So in the joint replacement world, we're making our decisions on X-rays. There are times when an MRI will change the decision making. Not for the average arthritis patient in general. Most of our patients, when we talk about arthritis, that we're going to see the signs on X-ray. You're going to see decreased joint space. You're going to see sclerosis or whitening of the joint. You're going to see osteophyte formation. When I'm getting an MRI for a patient that I think needs surgery, it's usually because I'm looking at other things that may add up to arthritis. So what we know about meniscal degeneration, meniscus tearing, about half of our patients have it if you get an MRI, even if they're asymptomatic. And so in both the hip and the knee, we now know that a torn meniscus or the labrum, which is a ring of cartilage in the hip, it's very similar. Degeneration of the labrum or the meniscus with mild arthritis is effectively treated with joint replacement. And surgeries to address the meniscus or the labrum don't really solve the problem if they're still an arthritic joint. And so especially there's new research in the hip about the validity and benefit of joint replacement in significant labral degeneration. So MRIs don't help us we don't need an MRI, but in special circumstances, the patient without a lot of arthritis, it helps evaluate other things that kind of add up to being a severe patient.
We talked a little bit about partial replacements. I think the only other indication for an MRI for what we do for a living would be to confirm that you only have arthritis in one spot in the knee, which would then lend us to probably offer a partial versus a total knee replacement. Very rarely use
vast majority no.
Yeah, I don't get MRIs for my partials routinely. I think it can be helpful, but it's still an intraoperative decision at the end of the day that you're capable of doing it when you look at the knee itself.
A couple of questions. When is robotic joint replacement recommended, or are the newer approaches to joint replacement, such as robotic, better for someone who's osteoporotic? And so I think this is an evolving field. So when you look at the literature on this, so big studies, do patients do better if you use robotic navigation or not? It's not clear yet. I think it's more important to pick a surgeon you're comfortable with, somebody's experienced, and it's the person using the tools. They're all tools to do the operation and how you use it. But that being said, in 5, 10, 15 years from now, do we think the field may go in that direction? Sure. But there's never been a study that shows that if you go to a joint replacement surgeon, who I think the numbers are like 50 joint replacements a year, at least, which all of us do by about 10 times, then it doesn't seem to matter. There's certain circumstances when it's better. But I would say those are specific. So go with the surgeon you like and talk to him about it, with the risks and the benefits. Like anything, there's pros and cons to it.
High volume surgeons at high volume centers have the best outcomes. It's an efficiency and a quality thing that's been studied over and over and over again.
Any questions out there?
Any risk to the plastic releasing toxins? We look at our implants, we think that they're as safe as they can be. Obviously, it's impossible to predict that. Certainly, we know from 20 years ago that, metal and metal hip replacements are not a good idea anymore. We try to use things that we think are safe. The wear rates probably dictate that risk, and the wear rates right now are exceedingly low. There just isn't a good alternative to the products we're using right now. So I think that's going to about wrap up everything we have today. We try to answer all the questions that we can. We do thank you all for joining us for this talk. We will be sharing a recording and uploading it to our website as well. You'll get an email copy of the talk, and we'll be happy to see you in the office and discuss any other questions you guys have.
Thank you.
Thanks.